In this segment, I'm going to briefly cover ICU sedation. I did cover some of these agents in intubation in the respiratory section, but I just wanted to kind of give a little bit broader overview here with ICU sedation and some of the common medications utilized. So first off, just identifying some of the issues and concerns when we're talking about somebody in an intensive care unit and looking at sedation and using medications for those purposes. Patients are, obviously attached to machines, things beeping, they're in a new setting, a new situation. There's lots of things going on. They're hooked up to IVs. It can be really problematic, really traumatic for our patients. And so, there's plenty of psychiatric symptoms that can go along with the process of being in an ICU and all the treatments and therapies that we're trying to do to that patient. So symptoms like agitation, anxiety, delirium, these can all happen based upon what's going on in their individual situation. Identifying a cause can be certainly challenging. Obviously, some of the big things, pain and infection, those are two really, really common things. From a nursing standpoint, monitoring for those things, looking for those things. We're talking about fever, we're talking about oxygen, low blood sugar, low blood pressure, withdrawal from certain medications, and then, of course, adverse effects, recognizing that medications we're using in that patient can actually cause or worsen symptoms. First line is non-pharmacological interventions. We do not want to use meds to treat any type of agitation and behaviors if we can absolutely help it. So making sure that patient's comfortable, assessing analgesia, making sure their pain is well managed, reorienting them to time and location, and maintaining normal sleep patterns, which can be super, super difficult in the ICU settings with lots of lights and things going on all throughout the day oftentimes. All right, sedation. So in many situations, we'll probably just want the minimal sedation possible. But in some situations, we may require deep sedation. So that's something, obviously, you're going to lean on the provider that you're working with, recognizing where we want that patient. And the selection of the agent that we're going to use will vary based upon the specific situation and other medical considerations. I did throw these on there just to recognize that we've got kind of varying sedation scales that can help us identify where the patient falls as far as how alert they are versus how sedated they are with what we're trying to do. I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. MedEd 101's Nursing Pharmacology Review course is built to make meds finally click. You'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed by pharmacology experts for nurses. Stop memorizing, start understanding pharmacology at meded101.com/nurse. Hey, nurses and nursing students, want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology Crossword Puzzle book from MedEd 101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse. All right, let's get into the medication. So propofol, brand name is Diprivan. This binds to multiple receptors in the central nervous system to interrupt neural transmission. GABA A is a big one here, but also can alter and bind with glycine, nicotine, and M1 or muscarinic receptors there. Very quick onset and very quick offset. So that is really advantageous. If the provider feels like we need to back off on dosing, we can do that very, very quickly with propofol, and that drug will be eliminated very, very quickly. The product itself is dissolved in what's called a lipid emulsion, and this can lead to some risks. And the particular one I think you should be aware of is propofol infusion syndrome. This is a dose-dependent effect, so the higher the dose and the longer the duration, this is more likely to happen. So elevations in cholesterol like triglycerides, rhabdomyolysis, remember that adverse effect is similar with statins, acidosis, low blood pressure, hyperkalemia, EKG changes and arrhythmias, acute kidney impairment, and liver dysfunction as well. So there's plenty of labs wrapped up into monitoring propofol's use, and plenty of vital signs as well. So from a nursing standpoint, recognizing any of those changes, making sure we get labs done on time, super, super important with this medication. Benzodiazepines, they activate primarily action on GABA A receptors in the brain, which gives its sedation type effects. Elderly, generally more sensitive to effects, which is, I guess true with most drugs, you could say. Midazolam, lorazepam, diazepam, those are the commonly used medications within this class. Midazolam has the quickest onset, gets into the central nervous system, and causes that sedation quickly. Lorazepam does contain propylene glycol, and it may contribute to toxicity from that. So extended use, more often we use lorazepam, more and more likely that propylene glycol toxicity may result. Tolerance with benzodiazepines can develop, so basically needing more and more of the drug to get similar effects. And naturally, benzodiazepines are one of the drugs of choice for status epilepticus. So in that type of situation where we've got a patient with seizure history, active seizures, benzodiazepines are likely going to be the drug of choice in that setting. Dexmedetomidine or Precedex, mechanism of action. This is a selective alpha-2 receptor agonist with sedative, analgesic-sparing, and sympatholytic properties. Remember that, parasympathetic and sympathetic nervous system. So less respiratory depression than other agents. So, benzodiazepines, they can really suppress that respiratory tract. Obviously, opioids can. If you overdose on opioids, your respirations eventually go down to nothing, potentially, if the overdose is severe enough. Low blood pressure and bradycardia. The easiest way I remember this is if you can remember the mechanism, the central acting alpha receptor agonist. This is the same as clonidine, which can be used for blood pressure and causes bradycardia as well. So hypotension, bradycardia. Patients are typically more easily arousable on this agent compared to propofol as well as benzodiazepines. Opioids, certainly important for pain management. Fentanyl is a commonly used opioid there. Again, respiratory depression risk is there with opioids, especially if they're used in combination with benzodiazepines as well, or at higher dosages. The more we push the dose, the more likely this is to happen. Be cautious about tapering down. If patient has been on chronic opioids, we can precipitate withdrawal symptoms. And in an ICU sedation patient, what's going to happen? It's going to display as agitation and behavioral issues, right? If that patient is experiencing withdrawal from a drug. If they're on other agents for sedation, be careful about patient waking up in pain, okay? So, pay attention to that, pay attention to pain management, and as we, pull patients out of their, deep sleep, whatever sedative level we're shooting for, as we get them to a more alert state, we do have to pay attention to that pain management and making sure that they're covered there for sure. So again, as a nurse, those assessments, those, maybe if they aren't able to verbalize things, paying attention to the body language of pain there. And then, of course, delirium, it can result. We want to do non-drug interventions, and we want to rule out other causes, whether that be medical or so on, other drugs, so on and so forth. Super, super important to do that. If we need a medication for acute delirium, antipsychotics are usually the drug of choice. Haloperidol is a first-generation antipsychotic. It does have the most evidence, but you will see a lot of the second-generation agents utilized as well. I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course.